Good
Thank you
day,
very
and
much.
welcome to Foley and Lardner's Emerging Community Hospital Networks, Forging Alliances to Remain Independent web conference. Today's conference is being recorded. At this time, I would like to turn the conference over to Mr. Michael Blau. Please go ahead, sir.
Thank you very much, Kyle. Well, good morning or good afternoon, depending on your time zone. My name is Michael Blau. I'm a partner and chair of the industry teams here at Foley and Lardner, and I have really the distinct honor of welcoming all of you to this webinar. This is the third in our hospital strategy series, and as Kyle said, the topic today is Emerging Community Hospital Networks, Forging Alliances to Remain Independent. We've assembled for you what I think is really a terrific faculty. It includes Nellie O'Gara. Nellie is a principal of HES Advisors. She was involved in helping to consult with and form the Value Care Alliance, which you'll hear much more about today. She'll talk about the business case for alliances and provide an overview of the national landscape for community hospital networks that are forming around the country. She'll be followed by Patrick Charmel. Pat is the CEO of Griffin Hospital in Derby, Connecticut, and he also serves as president of Value Care Alliance. And he really was the leading force behind forming VCA, and I think you'll all appreciate his remarks and perspective. He'll talk about the formation and plans for VCA, which is a statewide hospital and provider network in Connecticut. And then I'll bring up the rear, and I'll talk a little bit about the legal and structural considerations in forming a community hospital alliance such as VCA. Before we get started, let me just share with you a few housekeeping matters, particularly related to CLE. Today's program will run for about an hour and a half and will apply for 1.5 general CLE credits for the program. All New York, New Jersey, and Kansas attendees that apply for CLE credit have to fill out an attorney affirmation form. And if you take a look on your screen, you should see in the handout section an attorney affirmation PDF that you can download for that purpose. And each of you will need to submit that attorney affirmation. You'll also need to write down 2 course codes that will be announced at some points during the conference. So there'll be 2 of them. Please do write them down, get them in your attorney affirmation. If you also want a copy of the slides for today's program, they're also in the handout section, and they can be downloaded from your screen. We'll ask that you hold questions to the end. Questions can be submitted during the web conference by entering them into the Q&A box that you should see on your screen. And as time permits, at the end of the conference, we'll be more than happy to take as many of those questions as we can. Well, with that by way of start, let me introduce actually the topic for today. And I think it's fair to say that there's really a pretty pronounced and unmistakable trend in healthcare today toward hospital merger, consolidation, and affiliation. To share but one statistic with you, the number of hospital mergers per year since 2010, since the passage of the Affordable Care Act, has more than doubled. So we see an increasing trend toward merger, acquisition, affiliation. And Nellie in her presentation will give you all of the, or many of the business reasons for that trend. But merger and consolidation is not for everybody. In fact, for many community hospitals, it's a bit anathema. Many hospitals just don't want to sell out to or convert to a for-profit status. They don't want to be taken over by a large or a distant or a tertiary health system, whether non-profit or for-profit, and they're not really interested in changing religious sponsorship unless they really have to. Many community hospitals view themselves as they are as essential community resources, where all healthcare, as we know, is really local, and the boards of these organizations feel that they know best what is necessary to meet their community needs, and that they take the responsibility, and they take it seriously in terms of their fiduciary responsibilities and accountabilities to mobilize the resources to meet those local community needs, feel that they have been and should be viewed as treasured local resources and would prefer and treasure their local autonomy. So everything else being equal, they would prefer to remain independent if they have the opportunity to do so, if they can marshal the resources to allow them to do so. And for this reason, there seems to be increasing interest in the topic of today's seminar, that is, informing community hospital networks and alliances to remain independent in this rapidly evolving system, at least as an alternative to be considered for merger and acquisition. So let me close these introductory remarks with at least one legal point. I mean, I am a lawyer, so forgive me that. But and the point is this, that it's not as easy as it used to be to merge hospitals, particularly in a competitive marketplace, and particularly if the hospitals are in an overlapping market, that is, if they provide services in part of the same market. The antitrust enforcement agencies, the FTC, the Department of Justice, the Attorney Generals, are scrutinizing these transactions ever more intensely. And over the last 10 years, since 2004, they've racked up a somewhat impressive track record of successful challenges of hospital mergers. During that period of time, they've enjoined or unwound or gotten parties to abandon 10 transactions in a row that they've sought to challenge. Now recognize that's 10 out of the hundreds of mergers that have occurred during that period of time. So at least for some hospitals, merger may not be an option with their preferred strategic partner if they're in these kind of competitive overlap markets. And forming an alliance with that strategic partner may turn out to be a more feasible strategy, at least for some. So with that by way of sort of a little bit of a legal introduction, let me turn you over to Nellie O'Gara, and she'll give you an overview of the business case for alliances on a national scale. Nellie?
Thank you, Michael, and thank you all for joining us today. It's my pleasure to have a few moments to talk to you about our perspective on the role of alliances as the healthcare market continues to evolve. I'd like to start out by providing you with a couple of key takeaways. If you remember nothing else, I hope you'll remember these few things. First of all, the alliances are built for scale. And what I mean by that is individually, many hospitals may not feel that they are significant in their markets, but I can tell you that collectively, size does matter and size does play a positive and productive role. The second thing that I'd like you to keep in mind is that all of the alliances that we are familiar with are focused on a couple of things. First and foremost, efficiencies. And what I mean by that is getting their operating costs in line so that when they go to market and have an opportunity to contract, their price per discharge can be competitive. And secondly, in terms of efficiencies, looking at ways of sharing the costs of engaging in what is becoming an expensive set of resources, tools to participate in population health management. They're also focused on enhancing quality and the patient experience. And in the ones that we have worked with, the notion of sharing best practices is one of the key strategic priorities. When it comes to payer strategies, I think it's important to keep in mind that alliances can be selective with the payers that they're looking to contract with and focus on those that can enable both their efficiency and cost and patient experience strategies. And then finally, a couple of key ingredients. The CEO leadership and engagement is fundamental to getting an alliance off the ground and sustaining it. And secondly, persistence in the face of an ever-changing healthcare market is important to keep in mind. So with that, I'd like to go through a couple of slides that show you some of the alliances that have been formed and why they've formed and what we see as some business opportunities. First of all, the dynamics that hospitals or variables hospitals are having to deal with are quite numerous. But in our view, there are 5 that we think provide the impetus today to consider an alternative to being a standalone facility. Most hospitals, if not all hospitals, are worried about the first item that I have placed there. But the others depend upon the local market that you're participating in as to what extent these are issues for you. And I'd like to go through a couple of them. To echo what Michael said, about the consolidation activities. We put a trend slide together here that shows you the tremendous increase since 2008 or post-healthcare reform. What we're seeing on an annual basis, somewhere near 200 to 300 different affiliations or consolidations per year. And I think the question that one raises is this: are the expectations of the hospitals who are entering into these consolidated entities being realized or fulfilled? And the expectations today are very different than they were in the early 2000s, because the requirements to succeed in a post-health reform market are very different. And I'd like to ask my colleague and speaker, Pat Charmel, if he'd like to provide some perspective on that, given his own experiences.
Thank you, Nellie. Yes, a Griffin standalone community hospital, and I'll talk a little bit more about Griffin when we get into my segment of the presentation. Went through its own sort of assessment of its abilities to remain an independent hospital. And like many community hospitals, we've traditionally been fiercely independent. We did an assessment on our own, but thought to be totally objective, we'd bring in somebody external to the organization to really look at the kinds of capabilities our organization would need to not only be viable, but to thrive in sort of the new era that was emerging. So we did bring in Kaufman Hall, and the slide that's up on the screen is a table that they use as part of what they call their new era readiness assessment. And you can see over on the left-hand side a number of attributes that successful organizations will need in the future to thrive in that new era. And frankly, the assessment that was done was pretty sobering in that the capabilities that we have currently, or at least 3 years ago when we did the assessment, we were quite a distance from where we needed to be on many of those particular attributes or domains. Throughout that assessment process, we were contrasting the attributes and capabilities that we would need in the new era to those benefits that hospitals look for traditionally when looking at sort of traditional mergers into evolving systems. In the past, hospitals were compelled, as Michael said, and there have been a number of them across the country, have now been integrated into larger systems, have emerged, and in doing so have given up some degree of independence. In the past, hospitals have done that for a number of reasons. One, to gain leverage with managed care organizations, primarily in a fee-for-service environment to leverage higher fee-for-service rates. Looking at this sort of new era readiness assessments and the attributions we would need to be successful, we started to question whether, well, is that really productive going forward? Are higher fee-for-service rates necessarily going to be in our best interest going forward? Clearly, many folks have looked at scale opportunities to join a system, to improve the effectiveness of group purchasing, to share support services. But in some cases, those mergers have failed to realize the potential, or whatever potential has existed around lowering costs through more effective group purchasing or shared services was offset by system overhead that might be allocated to the hospital who was independent and now part of the system. Of course, many hospitals have looked to become part of a more capable system to enhance the kinds of services they could offer locally. In our own experience in our state where that's occurred, it's actually the opposite has been true. Services that were not sufficient volume or considered to be marginal by the system were eliminated locally and centralized, actually diminishing the capabilities of the local community hospital. And then, of course, a big benefit that everybody looks for when they're joining something larger is sort of a halo benefit to take advantage of the brand identity of the larger system. But one of the questions that we've asked, and I think more and more people are asking in a sort of a era of transparency and public reporting, we have to look at objective performance around clinical quality, patient safety, patient experience, and cost. And oftentimes, the system performance and systems built around larger tertiary facilities or academic medical centers on those particular measures may not look as good as their brand would indicate. So that led us to say, is there an alternative to a more traditional route, which is joining an existing system of the kind that I've described, and the alternative being aggregating with other fiercely independent, sort of like-minded, value-oriented community hospitals with lower cost and demonstrable lower cost and higher quality, and whether that quality being in the traditional clinical quality care process or outcome, patient safety, or patient experience. Knowing that in the future, looking at the attributes that hospitals will need to have to be successful in the new era, they're really going to have a strong relationship with the residents of the community they're serving, because patient engagement is going to be very important in an organization's effectiveness in population health management. So Nellie, that was sort of the context with which we sort of did our assessment and kind of thought about the differences between what it would take to be successful in a new era, one as an independent, maybe as a collective of similar hospitals, community-based, or the more traditional route of joining an existing system.
Thanks, Pat. And I'd like to go ahead and talk about another dynamic that is both a challenge but an opportunity for alliances. And many of you are experiencing the organization of independent physicians, either into IPAs or other joint venture organizations. And much of this has occurred of late in response to the opportunity that CMS provided to physicians to become involved in shared savings arrangements. It's been our experience that as those physician entities have gained experience and gained the tools and resources to participate with CMS, they are also at the same time participating with commercial carriers who to date have provided through PMPM arrangements some foundation for them to make the investment into the tools and resources of population health management. Well, this is leading many of these organizations to look at the opportunity to go further up the premium stream and to take risk on Medicare Advantage risk arrangements. I think the opportunity for alliances who can demonstrate a couple of things, both a lower cost position relative to larger existing systems, but who can also provide efficient management of patients both pre, during, and post-discharge through their relationships with pre-acute and post-acute providers, and facilitate transitions of care, provide data and information, and establish care management and care coordinator activities with these physicians groups, have a tremendous opportunity to tighten the relationship with some doctor groups who heretofore may not have been aligned with their own facility. I think this is going to become more and more important as alliances look at going into risk arrangements with payers themselves. The final area I want to talk about in terms of dynamics is payer strategies. It's been our experiences that alliances provide an opportunity for those payers who are willing to take a look at being disruptive in their marketplace. Not the number one in the market, but potentially the numbers 2 and 3 in the market who are looking for enhancing a product portfolio that can challenge incumbent health insurers and are willing to look at new models of both care delivery and payment to alliances, in fact, co-branding with alliances. So these are some of the dynamics that are happening. I think what I was seeing hospitals do is begin to ask a couple of questions. So given this backdrop, what is a vision for our organization that allows us to continue to be a valuable asset to our community? And can we achieve that vision on our own? Or do we need to look at some options from full asset merger all the way to a partnership or alignment? And the organizations that we're talking to right now are giving serious thought to the alignment strategy. And I think that's for a number of reasons that have been articulated to us. First and foremost, the alliance really honors the concept of local governance. And I'm echoing what Michael said at the beginning. It's about enhancing the individual organization's ability to achieve its mission and sustain its value to the local community. And we see this as a ready format for providers to look at opportunities for scale, opportunities for efficiency, and opportunities to spread best practices across a network of hospitals. And it also allows participants to get started working with each other in a fairly modest way that if things work out and they begin to build a level of trust and commitment to each other, there may be more close alignment down the line. It serves as an alternative, obviously, to a sale or change in ownership. And in our view, it can be a counterweight to the larger health systems operating in the marketplace. I think it's important for alliances to consider what their role is going to be both a partner to payers as well as physicians, who oftentimes are the organizations who are receiving the first contractual opportunities. And we see alliances as a opportunity for recapturing some of the revenue that has been leaking out of their facilities to the larger tertiary facilities by presenting a lower cost option. Let me review for you just briefly what we've been able to catalog in terms of some interesting alliance activity around the country. What I've provided here for you, and I would encourage you to visit the websites of each of these organizations. It will give you a good flavor for what some of them are considering and have taken on in their markets. But the important takeaway from this list of organizations is that this list represents small groups of independent hospitals that have come together. It represents more mature health systems who have decided to align with other hospitals. It represents academic medical centers who are looking to leverage their long-standing relationships with community hospitals in a more collective way. It represents some county and district hospitals that are looking at ways to work together because of the limitations of laws in their states. But primarily what I learned in looking at all of these is that they're focused on a couple of key things. And one is putting together the collective purchasing power to reduce their operating costs and sharing the cost of acquiring the tools and the resources to be successful in population health management. Sharing best practices, as I mentioned before, and getting organized to partner with payers and other employers in their marketplace. This slide talks to you about a couple of things. I tried to present some commonalities across the alliances that we're familiar with, and I'd just like to highlight a couple of key components across this. If you look at the first column on structure and leadership, I'm going to emphasize yet again the importance of CEO leadership and engagement. And in all of the alliances that we're familiar with, the CEOs meet regularly. I can tell you on the case of the Value Care Alliance, we are meeting on a biweekly basis, either by phone or in person. And it takes that kind of commitment to get a startup going and to stay persistent in the face of a changing marketplace. It's also important to engage other key stakeholders throughout each organization and have their buy-in to where the alliance is going. Staffing an alliance, in the ones that we've studied, has been interesting. It ranges from having hired their own staff. Many times staff is on loan from one or another organization within the alliance, and oftentimes consultants are providing leadership for a time being. The capitalization ranges from a low end of $400,000 to $1 million per hospital per year, depending on what the business plan is of the organization. Most of the ones that we're familiar with have started small without making major commitments until they have come to agreement on a business plan. Payer strategies have been interested, and the initial focus in getting real traction has been on taking a look at how you can improve the management of the health and welfare spend of the members' own employees, who primarily the organizations are currently at risk for. And then in terms of population health management tools and resources, it's oftentimes directed at initially getting the data and analytics in place for identifying the opportunities with your own employees. Shared services run the gamut, but most often they are non-GPO services. In a few cases, some of the alliances we're familiar with have gone to a single GPO. Many of them are looking at a single HR office, combining their IT back offices, looking at opportunities for a single reference lab testing vendor, and even exploring the opportunities of reallocating lab services around the network. And in terms of clinical integration, one of the ones I've been very impressed with has their chief medical officers from each organization meeting on a regular basis, and they have developed evidence-based guidelines for a number of chronic disease management challenges, and they have put in place these guidelines across the network, and the hospitals are measured against them. So that gives you a pretty quick profile of some of the things that are going on. I'd like to end with a couple of challenges that I see for alliances. And that is, first of all, the real versus perceived, quote, value that alliances can bring to a marketplace. I think there has to be a commitment to lowering the trend, the total medical spend, and that in some cases may require some members of an alliance to think about a reduction in their reimbursement. There can be a clash between what the market wants to buy and what the alliance is offering. I think the important opportunity there is to work with payers who are willing to work with you to phase in a strategy over time. Many of the payers that we've talked to are certainly interested in hospitals taking risk and hospitals and integrated delivery systems, but they recognize that if those hospital delivery systems fail, they will fail as well. It's also important that the variability and the strengths and the weaknesses of alliance members be smoothed out. And so I think it's important to set performance targets that each member will commit to and put in place the operating procedures to get everyone to a benchmark that's high in the marketplace. When it comes to addressing the needs of potential members, I think it's important to point out that this is not necessarily a place where hospitals that need capital are going to be able to turn to and get that capital without a more significant commitment to each other. So I would think that this is an opportunity for those who are not necessarily looking for a loan for their operations to be going. And then in terms of building out the strategy, there is a required investment. I think you can crawl, walk, run in terms of that. And then finally, when you're putting organizations together that are of like mind, they still have individual perspectives. And I think it's important, therefore, to have a decision-making process that facilitates speed to market and doesn't get hung up too much on not being able to make decisions. And so with that, I think I'd like to turn the presentation over to Patrick, and he can provide us with a perspective on Value Care Alliance.
Thank you, Nellie, and that was a great in sort of putting what I'm going to talk about in context. Just want to tell you how the few minutes I'm going to spend is organized. I want to start with an overview. I want to talk about the environment that the hospitals currently participating in the Value Care Alliance faced. at formation and what we see in the environment going forward. Describe the characteristics of the current participants. Very important, and this is something that you just addressed, Nellie, the commitments that our members are making, because they're serious commitments, and people have to fulfill those commitments for the Alliance to be successful. I'm going to spend some time talking about the schedule as well. This is a big undertaking, and it takes longer than you might expect, and frankly, it's taken longer than we've expected, but there's been a lot of learning along the way, and maybe we can give you the benefit of that learning, and we can shorten the timeline a little bit. And I want to share at the end some of the lessons that we've learned in our initial formation, in the decision-making that we've had to make, and the data that we need to support those decisions. That data has been difficult to acquire in some cases, but with growing transparency going forward, we think there will be more important data, meaningful data available, so this might get a little easier for those who follow us. What it takes to manage the process, and staying power is really important. We've encountered a number of obstacles along the way, and we expect that we'll continue to encounter those obstacles. Perseverance is really important, and describe a couple of points about what we think is necessary to stay the course. Talk about the environment that we face and the current market dynamics. And again, some of this is specific to Connecticut, but I think it's generalizable to most parts of the country. Sort of a specific, just in terms of context, Connecticut imposed a provider tax on hospitals about 2 years ago and cut pretty dramatically uncompensated care payments and other supplemental payments, about $500 million over 2 years, and essentially there are only 30 hospitals in Connecticut, so you can kind of get a sense of the order of magnitude. At the same time, Medicare increases, although if you look at the market basket increase, it wasn't terrible, but when you net out other reductions, essentially hospitals who are looking at flat or negative Medicare reimbursement over the same time period. Traditionally, we would react to that as hospitals to try and shift any state or federal payment shortfalls to commercial payers. In the past, those commercial payers were somewhat willing to accept those cost shifts because they had pricing power. Essentially, they can turn to the folks to purchase their products, which is the employer community, and pass that shift onto them in the form of a larger premium increase. But frankly, what we're seeing in Connecticut, and I suspect this is the case across the country, you see the employer community pushing back. They started to push back probably 3 or 4 years ago. The way to mitigate some of those increases were pushing more of the cost of healthcare onto their employees in the form of larger premium shares and higher copays and deductibles, but I think most employers have exhausted that, with employers in Connecticut now asking employees to pay 30% of the premium on average, and higher deductible plans are pretty common in the marketplace. $3,000 and $5,000 annual deductibles are not uncommon, so employers sort of exhausted their ability to shift any increases in premium to their employees, and so they pushed back on the health plans. And health plans that have been reluctant to enter into any kind of advanced payment model have now realized that they need to pursue those to ultimately reduce the total cost of care and therefore allow them to maintain or even lower premiums, which is something that was unheard of 3 or 4 years ago. So that's sort of the payer environment and some of the cost pressures that exist in the market at the time of formation. And just in terms of consolidation in Connecticut, there are 2 major health systems in Connecticut, each built around a tertiary regional referral center. One is a large academic medical center. That large academic medical center system recently partnered with a for-profit company, a national public company, in part to bring capital and capability. Both systems have a desire to expand, and they're rapidly expanding their physician enterprise. In one case, you have one of the 2 systems just recently acquired a large independent, formerly independent physician organization. All major payers, as I said, now are really looking at advanced payment models, including shared savings arrangements. At least their initial foray has been to offer those shared savings arrangements to independent physician organizations, especially those with a strong primary care base. Again, their attempt is to lower the total cost of medical care. And those organized physician entities are trying to build their capabilities to manage populations, and they've been relying on the support of managed care companies in the form of per member per month payments to support that infrastructure build. But we are hearing from payers and actually from the independent physician groups that have these relationships that payers are getting somewhat impatient, and there may be a reluctance to continue that support going forward unless those organizations can actually demonstrate results. Important to note that those physician organizations, up until very recently, have prided themselves on being hospital agnostic. So in terms of the next moves that we expect in the market as the market begins to evolve or continues to evolve, again, what those payers are looking for is, for them, it's all just like it is for the provider community. It's about growing your business. They recognize that they're going to have to begin to offer products in the marketplace that offer a premium advantage, certainly to stabilize costs for employers who are purchasing their product, but ultimately to begin to reduce the cost of care, and they're willing to do that now in innovative ways. They're, for the first time, considering narrow networks or tiered network products, although there are some prohibitions to offering tiered network products for the fully insured product in Connecticut. There's a regulation that exists right now in the Department of Insurance that prohibits fully insured products from having tiered networks, but they are available to those employers who are self-insured, and many of you know that more and more employers are becoming self-insured, which used to be sort of a large employer phenomenon. The size of the employer base that's moving to self-insurance is shrinking. Now you see employers with employees of somewhere between 100 and 200 becoming self-insured. Again, the expectation in the marketplace for these new narrow or tiered network products is that they need to offer a significant cost reduction or premium differential, 10% or more. Again, to be able to offer that in the marketplace, you need to work with providers who are organized in such a way that they're going to actually be able to achieve the reduction in total cost of care. And so there needs to be tight alignment and integration to achieve that, and that's what we're seeing. As the Value Care Alliance began to form, again, these were like-minded community hospitals that want to maintain their independence, looked at the capabilities that they need to develop to be successful in the marketplace that's evolving. And so those hospitals came together with independence as a bias. They certainly want to maintain that independence. They want to grow. They know that's essential, especially because we expect utilization rates to decline. We know that the pie is going to be shrinking, and our viability depends on being able to get a larger piece of a shrinking pie. So in almost every case, Value Care Alliance member hospitals, again, which are independent community hospitals, are seeing leakage out of their primary service area. Those are primary service area residents who are choosing to receive their care in a competing hospital, and in many cases that competing hospital is a larger tertiary facility with higher costs. So obviously our motivation in trying to grow our business is to reduce that leakage and have a greater percentage of the community population choose the local hospital versus their competitor. We know to do that, we need to enhance our low-cost, high-quality position. To achieve that, we need to share our capabilities and our best practices. And when in coming together, and we'll talk about that in sort of the philosophy that's developed, is that there is a real commitment to sharing. And even in those cases where alliance members may be competing for pieces of their market, there is a real commitment to, in spite of that need to compete, also to enhance capabilities, recognizing that if the alliance gets stronger, every member gets stronger. And as Nellie mentioned, clearly with advanced payment models, employers moving towards risk-based arrangements with payers, we have to develop the ability to manage the health of populations. Many of us have very rudimentary capabilities now. We know that there's a significant investment required, and many of us were not capable of making that investment on our own. As I mentioned, our philosophy, sort of the foundation of the VCA, is that care that can be delivered locally should be. One, it's going to be more responsive to the needs that those we're serving, but we also know for many of us that care is not only going to be more effective but efficient, given that the alternatives would be to have that care delivered in a higher cost venue. We also know that to bring about the level of alignment we need to effectively manage populations, we have to give physicians a seat at the table, and they have to be intimately involved in the development of the alliance, its governance, and sort of the operational development as well. We see the VCA as a collaborative organization with each member organization, in some cases standalone community hospitals, in one case a system, that it needs to be a collaboration between those members, but also at the member level, a collaboration between the hospital and its medical staff and community physicians. In many cases, those members have an existing alignment strategy locally, and we're trying to encourage that and also ensure that it's effective as possible. And in terms of payer relationships, and this is an important point, previously in a fee-for-service environment, many times the relationships with payers was somewhat antagonistic. That needs to change. The VCA has had numerous conversations with payers in the marketplace, and we really believe that it needs to be a new era of working with payers, and it has to be in a very transparent way, especially if the basis of our discussions are on our performance, both in terms of quality and cost. We're sharing information openly and want to make sure that we can demonstrate that we can deliver what's necessary to be successful both for the payer and for the alliance members. Just in terms of continuing with the organizational philosophy, this particular organization does not have an interest in developing a competing health plan. We really do feel that we can form productive relationships with existing payers, and frankly, we find that payers are a little bit leery of working with organizations who may have, as part of their agenda, developing their own health plan. We don't see that in our future. We do see the possibility of developing private label products in some kind of a co-branding or a joint ventured way, but we really do believe that a relationship with the payers brings value and capabilities that we can exploit. As Nellie said, cost is going to be a key driver in the future, so we have a strong commitment to effectively managing cost. And ultimately, in terms of population health management, again, one of our motivations for coming together is to build core competencies and the infrastructure necessary to manage the health of populations. We know it's going to take some time to do that. We don't want to delude ourselves. We know that there are providers in the marketplace who have developed some capabilities, and even within our own ranks now, we have some members that are more advanced than others, but even the most advanced maybe have a 6 months or a year advantage in terms of what they've been able to create, In many cases, those are early generation capabilities that will be replaced by more advanced capabilities in the future. We are committed to managing a patient care in a way that is measurably superior. There are many providers in the marketplace tout their capabilities, but we recognize we're moving into an environment of transparency where we will be paid for performance, and we have to demonstrate that. So whether that's clinical quality, patient safety, patient experience, we want to make sure that as we try and remove the variation in care that exists and some of the redundancy that exists as patients move along the continuum, all of our decisions in terms of treatment protocols, in terms of our disease management capabilities, they all need to be overseen by physicians. It needs to be physician-driven, and ultimately we need to offer value not only to the payer, but the employer who's paying the bill and the consumer who going forward is going to be responsible for a larger piece of the actual cost of care. We are being fairly deliberate in how we go about selecting members to participate in the Value Care Alliance. Obviously, we have to make sure they fit our cost and quality profile, because ultimately that's the basis on which we'll compete in the marketplace. Having an appropriate geographic footprint is important in working with payers. They're going to be held to tests of network adequacy, so we know that it's important that we cover the geography appropriately, especially key markets. Physician alignment, we're looking at each individual member and potential members' current level of alignment and what structures they have in place. And again, there's a continuum for those that are fairly mature in this regard, and others are in early stages. And again, there is a commitment to work together and learn from each other and look at the vehicles that have been developed and the practices that have been adopted, and so that each may look at those best practices or the most effective structure and adopt those. Again, there's this burning desire to remain independent, but independent in a way that we now begin to collaborate with others who are like-minded. And again, the willingness to make the kinds of commitments that I'm going to talk about in a second. And here are those commitments. The willingness to participate in governance and leadership of the organization, and to have appointed representatives to serve on not only the board, but various committees, which I'll describe when I show you a graphic in just a minute. Also willing to work with the VCA as their representative in contracting with payers, particularly for sort of new generation products. I mentioned narrow network, tiered network, and other advanced payment structured products. We really want the VCA members to be working together with payers, so we're asking members to give the VCA a limited right of first opportunity, and Michael will talk a little bit about that in a sort of more formal way. But we're all committed to have the VCA be our agent in that regard, and hopefully be able to VCA develop relationships and bring sort of terms back to us that are acceptable and serve the needs of each of the member organizations. And again, ultimately, for us to be able to offer those kinds of products that offer value in the marketplace, we do have to meet very specific targets in terms of cost, quality, and efficiency, and that is part of the commitment that members are making, and that actually is absolutely necessary for us to be successful. Again, I talked about clinical integration and developing alignment locally. It's important that each make a commitment to do that, but not only do it locally, independently, but work with others in the alliance to achieve that. And again, our population health management capability, not only in developing third-party products and making the necessary investments, but actually to operationalize that there has to be a level of commitment to collaboration across the alliance. Shared services, Nellie talked about that. We believe that there are opportunities for independent hospitals, community hospitals to work together through an alliance to get the kinds of economies of scale that maybe were only available in the past through formal integration into a larger system. We've already identified a number of opportunities to share various kinds of support services. Nellie described a couple of them. There are many, and there is a real appetite on the part of members to pursue those, because those are the kinds of things that will be necessary for us to reduce our costs to the level that will be necessary to compete in the marketplace. And of course, and Nellie referenced this as well, there has to be a commitment to fund the development of the infrastructure necessary for the alliance to be successful. This is a map. I was talking about network adequacy. This gives you an idea of where our hospitals are located geographically. I'm noticing on the screen that you may not be able to see the circles that are on the map. I apologize for that, but what we're seeing is, right now our current membership covers most of the major population centers in Connecticut. There are a number of other providers who are talking to the Value Care Alliance about membership. Again, that's a bit of a process that we're going through to do the profiling that I talked about earlier and to talk about the commitments required on the part of members. But in terms of current VCM members, they represent about 90,000 inpatient admissions, about 34,000 Medicare admissions, about $2 billion, in revenue generated on an annual basis, and you can see some of the other characteristics we have in capabilities. At the bottom where it talks about economic impact, important to point out, current level number of employees of existing members is about 11,000. If you're talking about employer-provided health insurance, the number of covered lives for our employees and dependents is in excess of 20,000, closer to 25,000, which, as you can imagine, creates some opportunities for us in terms of managing the health of our own employees and helping to control and possibly reduce that cost. We span over 85 communities in Connecticut and reach a population of almost 2 million. I mentioned before one of the goals is to reduce leakage. One of the principal reasons for the Value Care Alliance forming is for community hospitals to be able to get a larger piece of a shrinking pie, and you can see here that the current members of the Value Care Alliance, to varying degrees, have a fairly good percentage of their local population, those are folks living in their primary service area, receiving care out in a hospital other than the member. So I'll use Griffin Hospital as an example currently, and just in terms of Griffin and its competitive landscape, Griffin sits in between 3 of Connecticut's 5 largest cities. Each of those cities has 1 or 2 hospitals with that are much larger with a lot more clinical capability. It's a 12-minute drive time to any one of those cities from Griffin's primary service area. So about 70% of the commercially insured population living in our primary service area receives care elsewhere. And you can see in some cases that's being cared for by one of our system competitors. That happens to be the anchor of that system is drawing a lot of business out of our primary service area market, and that happens to be a much higher cost venue. And you can see going down the list for the other hospital members of the Alliance, you can see a similar picture, although we have a couple that dominate their marketplace to a greater extent, Danbury and Lawrence and Memorial, but in every case looking to reduce leakage. In terms of our performance, our relative performance on sort of objective measures, those are the, if you look at composite of core measure scores, those are Medicare's process indicators. You can see that the Value Care Alliance hospitals compare pretty favorably with the system competitors in the marketplace, and the same thing for patient experience. Again, these are high-performing hospitals, as indicated by the kinds of recognition and awards these hospitals have achieved. Clearly, we're offering a competitive alternative to the existing hospitals in the marketplace, to the two existing systems in the marketplace. Again, we compare very favorably on cost and quality. If you look at the Alliance as a collective, it has a significant presence in terms of market share. I think we can fairly say, if you're looking at the new Era Readiness assessment that we went over earlier, I think the Alliance as a collective is essential in the marketplace. We collectively have a number of assets that we believe that we can exploit. Physician entities, a fairly high level of alignment already existing, a comprehensive ambulatory service delivery system, and significant inpatient and post-acute capabilities. And as I said, in terms of population health management tools, we have capabilities that exist. They vary across our membership. Some are more advanced than others, but we all have the opportunity to work together now to sort of develop the next generation of population health management tools that are needed to be successful, especially in an environment where we'll be taking risk in the marketplace. Just as it relates to risk, those managed care organizations, frankly, have been unwilling up until now to enter into truly advanced payment arrangements beyond shared savings, in part because they may have thought that providers weren't, frankly, didn't have the capabilities to effectively manage that risk. It could have been because they were concerned about potential disintermediation. It's a term that the payers use, that if they begin to delegate care management and the sort of aspects of sort of the payer realm that was really their domain previously, it would question sort of their value in the marketplace. But given the pricing pressures that they've encountered, if you look at the minimum medical loss ratio sort of provisions that are in ACA that limit how much they can take out of the premium dollar for overhead and profit, there seems to be a new willingness in the part of payers to enter into arrangements where they truly are delegating a substantial part of the premium to organized entities that include physicians and hospitals, and I think we're now well positioned to take advantage of that willingness on the part of payers. In terms of our structure, it's outlined here. Very important to note the strong role that physicians will play in the governance of the Value Care Alliance. You can see in the box on the upper right. In terms of board seats, 3 for each member, but 2 of those 3 board seats will be held by physicians from member organizations. Also important to note at the bottom, again, we can have aspirations, we can have a level of commitment, but we actually have to be able to operationalize this. And you can see at the bottom, we've put together a number of working committees that are multidisciplinary and have representatives from across our alliance to look at the information technology that we need to develop the level of clinical integration required. We have a committee or working group that's working on payer contracting, and as I talked earlier, to identify and pursue shared savings opportunities. Just to wrap up, and I'll turn it over to Michael. Again, this graphic sort of displays in kind of summary fashion sort of the mission of the Value Care Alliance, our specific goals, which I've talked about, and the various priorities that we have. I think we've covered most of these. The timeline, very important. As I said, there may be an ability for those that come after us to take advantage of not only our experience, but some of the other alliances that Nellie referred to that have formed around the country who are also very willing to share their experience. There was a 6 to 9 month development phase for the Value Care Alliance. We needed to look at each of the hospitals and their cost and quality profile. Obviously, we had to put together the structure itself, and we see that in kind of the second portion of the arrow, that second 6 to 9 month period. We forming the entity itself, developing operating agreements, the various levels of initially memorandums of understanding, term sheets, formalizing that into working documents and ultimately get them adopted. We've then sort of moved on to developing our business plan, talking about what kinds of capitalization that we need, talking about ultimately what do we need in terms of network adequacy and building out our network. And then to the point now where we're talking about how do you describe this in the marketplace, developing a communication strategy, and then looking at the specific tools that we need to be successful. Ultimately, the lessons learned, as Nellie mentioned earlier, CEO leadership is very important. Not only commitment, but actual engagement and involvement. We have a great leadership group. The CEOs are very much engaged and willing to sort of participate in what really we've created, which is sort of a learning environment. We're learning together, sharing our capabilities, figuring out together what is going to be needed to be successful, and willing in many cases to subordinate the interests of their individual organizations to sort of to the needs of this collective, which I think everybody recognizes is going to be important to their long-term success. Obviously, network composition and building out the network is very, very important. Physician alignment and engagement and working through that in a way that's very sensitive to the interests of physicians, especially those that are already in organized physician entities, and figuring out the role that we're going to play, recognizing that many of those entities already have arrangements with payers that are incentivizing them in certain ways that currently might be at cross purposes with the interest of hospitals. Again, I mentioned sort of data, resources, and sort of getting access to the data that we need to make informed decisions. Some of that is available. Some of it is harder to get. Really important to focus on that. We recognize that there is this growing move towards transparency. In Connecticut, there's an all-payer database that's been mandated by the legislature. That information is not yet available, but will be shortly. And I think that will start to be so it will cause sort of a sea change in the marketplace because we'll see information about payer cost and payment rates that we haven't seen before. We do expect some retaliation when you start to talk about product design, plan design that steers business toward some group of providers. In our case, we hope it's going to be the Value Care Alliance providers and away from others, including higher cost tertiary providers. There may be retaliation in the marketplace, and we recognize that we have positive working relationships with many of those facilities that are very important for us to maintain. So figuring out how to do this to advantage our organizations and to maintain those relationships is a challenge, and it's something that we continue to work through. And we recognize that not all payers and not all providers will play in the marketplace. And that's very important to understand. That's been something that has taken us a little bit time to sort of adjust to. When we built sort of an ideal network and put it on paper that would sort of meet our aspirations for performance and cost and quality. Not every one of them, for whatever reason, some local, are going to necessarily want to participate. And so we have to accept that and sort of engage those that are and make sure that we can be successful with those that we're working with. And again, this takes much longer than you might expect. There are going to be costs associated with this, and decision-making is going to be a little bit more challenging than you might expect. I think what we learned is our strength is the fact that we're bringing together organizations that are fiercely independent and want to maintain their independence and are willing to come together and build an organization like this to help them maintain their independence. But by definition, they are independent, and they want to make decisions independently, and we're asking them to, again, come together and make collective decisions. And we've been very impressed with the commitment of our members to do that, but recognizing these are folks that have stayed independent because they want to make decisions that they believe are in their best interest of their organization and their community. So with that, I want to turn it over to Michael, who can talk about the actual structure of the organization that we've put together and share some other thoughts. Michael?
Thank you very much. Actually, thank you for that really tremendous overview of Value Care Alliance. And one thing that you said really resonated with me, which is that this has been a learning experience, I think, for everybody. And this is a learning lab for a very new generation experience to build this kind of alliance. And I think to be successful, you have to view it that way. So I think that was a great insight on your part. Let me take a pause for one moment. For those of you who are looking for CLE credit for this program, let me share with you the first CLE code. The first CLE code is YOOM. Again, Y as in yes, OOM as in mother. Okay? With that, let me pick up exactly where Pat left off, which is with some legal and structural considerations in the formation of alliances in general and VCA in particular. Sitting with Pat and his leadership team and the other CEOs, I mean, you become, first of all, humbled by their intelligence, but you recognize the old adage that form follows function. To create one of these new organizations, you really have to understand what it is that the parties are seeking to achieve. And we have to work with that palette. So let me just highlight a few of the things, and some of this echoes or reiterates what Pat had said, but they really were the structural skeleton, the bones on which we have built VCA. And I think, if you look at any of these alliances that Nellie described, if you've seen one, you've seen one. They're all quite different, and they were all somewhat architected for slightly different reasons and customized to their particular markets and participants. So here, we knew we had to create an organization that's going to be attractive to the payers, that would have the network adequacy, that would have the quality cost value-based providers, that would be attractive, and attractive to bring the hospitals in that needed to be brought in, that would provide that geographic diversity regardless of their size. So this could not be an organization that could be dominated by large hospitals or small hospitals. They all had to come in basically on an equal footing in some fundamental regard. It had to be not only attractive to payers, it had to be attractive as well to physicians, to IPAs, to PHOs, and to other ambulatory care components that we ultimately will need to do business with in order to coordinate care across the full continuum as this organization grows, matures, evolves, and becomes a real population health management vehicle. And to do that, we needed to have ways in which all components of the system ultimately could be engaged as active participants in the dialogues and the governance in the various structural organizational elements of the Value Care Alliance. And we'll show you, Pat has showed you the organizational chart, but I'll take you a little bit deeper into how we attempted to achieve that. We recognized that there could not be domination by any faction, that there couldn't be oppression of any faction either. And so, the larger systems couldn't have a larger voice than the small hospitals. The hospitals couldn't have a larger voice than the physicians. The primary care physicians couldn't have necessarily a louder voice than other physicians, and so on. We also recognized that we are in an evolving marketplace, and so whatever it is that we came up with was going to have to be flexible and adaptive, both in terms of the market response and in terms of bringing in new types of providers over time and taking on new business responsibilities over time. So all of this needed to work. We need to have equitable participation and rewards, and I'll come back to that in a moment. So you can look at some of these guiding principles by which we sought to design the value care alignment organizational structure. During the design phase, which is shown here on this slide, we took the transactional steps that one would normally expect in a transaction of any nature, but particularly of this nature. We had a confidentiality and standstill agreement among the founding members so that we could have the kind of candid dialogue necessary to form the organization. We identified the commitments that Pat articulated earlier and wrote them into a letter of intent, a memorandum of understanding for the founders to sign onto, so that we were clear with our foundational elements and had them in place. There was a lot of work that was done, as I think Pat described, around the strategic assessment and due diligence to make sure we had the right members in that would be able to bring value to the Value Care Alliance. And we ultimately developed definitive agreements, which were principally two, an operating agreement for a limited liability company, which we'll get to, and a participation agreement, of which there'll be various flavors of that participation agreement for different provider types. The purpose for this alliance entity organizational chart, if you will, is just to make the point that at the outset, the CEOs developed a business plan in coordination, in conjunction with HES advisors and Nellie, and that business plan pointed to the opportunity for profit and return on investment. That they saw that probably somewhere about 3 years out, if they did this right, that based on VCA becoming a risk-bearing entity and a successful risk-bearing entity, and based on some of the GPO and shared savings type of activities that it could engage in, where it could get service fees and potentially generate a profit, that this probably should be viewed as a for-profit enterprise. And that since there were very substantial capital commitments that were going to be necessary in order to realize the business plan, that there should be commensurate return on investment, that risk should be paired with reward, that those who are invested should have the opportunity to reap that return on investment. And so as we began to think about this, we did incline ourselves toward a for-profit enterprise. And so when we took a look at the structural options, we relatively quickly dismissed going down a nonprofit tax-exempt route. Sub-S we couldn't do because we were going to have corporate members, and we were left really with a choice between a limited liability company and a for-profit C corporation, and ultimately chose to organize VCA as a limited liability company, principally because it's a tax pass-through entity. And as we look down the road and hope and expect that we'll have the opportunity to become a risk-bearing entity that would have to have surplus and reserves, if we were to try to retain those surpluses out of earnings in a C corporation, it would get double taxed, would end up paying the government 40% or so of those revenues, and would be less available for reserve and insolvency protection purposes. And so we went with a limited liability company with a tax pass-through, without any significant concern, at least at this point, of generating any substantial unrelated business taxable income for the nonprofit hospitals that will be its members, since we expect that most, if not all, the activities that the VCA will engage in will generate related business income, not unrelated business taxable income. So that next couple of slides you can look at your own, but that sort of talks about the reasons why we went with the choice of entity that we did. Another set of preliminary considerations that we had in our focal point were antitrust considerations. I mentioned one at the outset, but in forming the alliance, there are questions about how large you can be, how many hospitals you can bring in within a particular market, and how exclusive you can have those hospitals be to your network or alliance. There are questions about how you go about payer contracting so that you don't get yourself involved in price fixing and collusive pricing. There are questions about how you avoid market allocation in the work that we will be doing and making sure that we don't engage in any type of concerted refusal to deal with payers or vendors or others. There are questions about how we go about doing joint purchasing so that we don't seem to or actually have monopsony power, market power as a buyer, and use that in an inappropriate way. And there are questions about how do we information share? How can an organization like HES provide some useful benchmark or survey information to help to inform pricing without facilitating collusive pricing in a way that would be violative of the antitrust laws? And fortunately, or depending on your viewpoint, at least we have some guidance from the Department of Justice and FTC in terms of their statements of antitrust enforcement policy that were issued in 1996 on many of these topics. And let me just give you a flavor of some of these as it related to the formation of the VCA. So on the question of how large we could be and how exclusive we could be or should be in order to assure compliance with antitrust constraints, the first thing to think about is, do you have competitive overlap markets for your hospitals? If I've got one hospital in the northeast corner of the state and another hospital in the southwest corner of the state, and they're really not drawing from the same patient population, we don't have an antitrust issue when it comes to bringing them together through an alliance. But if they're in any type of relative approximation where they are sharing some potential draw markets, then we have to make sure that whatever we do with this alliance, that the competitive benefits of the alliance, the pro-competitive benefits of the alliance, outweigh any anti-competitive effects or potential anti-competitive effects of the network. And here, I think it was clear that the core purpose of the alliance was to produce cost savings and premium savings in ways that are intended to redound to the benefit of employers and consumers, and really should be viewed fundamentally as a pro-competitive entrant into the marketplace. But there's still questions about, in particular submarkets, how large you can be. And if you take a look at the safety zones are going to say you can have 20% on a an exclusive basis, 30% of the market on a non-exclusive basis. If you're a Medicare ACO and there's special guidance, you can be 30% on an exclusive basis. But those are relatively paltry market shares, and as Pat showed you earlier, at least within their primary service area, these hospitals all have larger shares than that, or most of them have larger shares than that. If you take a look at the FTC decisions, I think you'd come to and DOJ decisions and court decisions, you would come to the conclusion that you can probably get up to 40 to 60% of the market before you really begin to raise any substantial antitrust question, never mind concern, and that can be largely mitigated by making sure that that there are other options, that perhaps that it be a non-exclusive participation. And that's the direction that VCA took. They said that the network will be non-exclusive, that all we're asking for in order to give the glue to the network is that each of the hospital participants and providers commit to a limited right of first opportunity for specified payers and products. But it's only for that particular product, the new generation product that we're going to be developing probably on a private label basis that doesn't already exist in the marketplace. If the participants want to have contracts with the same payers for other products, that's fine, and they can participate through other networks and alliances and through other systems for those contracts. But we just ask that the one or two specific unique products that we are creating, that they refrain from participating through any other network with a specific product of that type that would compete directly with the product within this value care alliance. And with that, we think it's pretty clear that the pro-competitive entrant in the marketplace to reduce costs would outweigh any potential anti-competitive constraints that would flow from that minimum restriction of a limited right of first opportunity. The second, big antitrust question is how do you go about payer contracting without for price fixing? And as Pat and Nellie indicated, during the first phase of this network, the types of products which they're looking at are shared savings with upside only, no downside risk, and with limited tiered or narrow network products with the payers. All of those are variants of non-risk contracts. And when independent organizations get together and want to negotiate rate for non-risk contracts, they can't do so consistent with the antitrust laws unless they do it through a modified messenger model or a messenger model approach. And the approach that VCA has selected is a modified messenger model. For those of you who are familiar with IPA and PHO, contracting and facilitating contracting arrangements, you're probably familiar with the vernacular of messenger model, modified messenger model. But in a moment, try to do this quickly. A modified messenger model approach involves each participant, each hospital, independently and unilaterally declaring what its price will be. The hospital will say something like, I'll take 120% of Medicare rates. Each hospital, though, will do that independently, unilaterally. It will provide that information to an organization like HES on a black box basis, meaning that no other organization knows what hospital A is choosing for its rate, and the only person who has that common knowledge has to keep it confidential. So if it's Nellie, then Nellie would be the black box. Information would go out, it would go in, and it would not be shared with anyone else. She, though, when she gets a bid from a payer at, say, 120% of Medicare, would know how many hospitals in the network she could deliver at that rate and how many others would need to go through a separate negotiation process to come up with an acceptable rate that would be mutually agreeable both to that individual hospital as well as to the payer. So that's the modified messenger approach. This next slide talks about clinical integration, and I feel like this is the great provider and suburban myth of clinical integration. At the outset, I told VCA, for reasons that I'll explore a little bit more deeply with you, that it was highly unlikely that they would, in the foreseeable future, be able to get to single signature pricing, to be able to get to single signature contracts with the payers, that is, to jointly negotiate, collectively bargain for rate based solely on the back of clinical integration. There are many organizations, many clinical integrated networks that purport these days to say that they're trying to do that. But it's one thing to do it, to try to create clinical integration as a foundation for joint pricing within a single hospital or a single PHO. It's quite another thing to try to do it across a statewide network of separate organizations that you're trying to bring together on a clinically integrated basis. And I think that's the cautionary tale that comes out of the Suburban Healthcare Organization FTC advisory opinion that's cited in the middle of this slide. There were multiple PHOs that sought an advisory opinion that said because they did the right things, they came up with common protocols, they came up with common information technology system, they made some substantial investment in those systems and protocols. They had a process for disciplining and assuring compliance with the protocols across the system. The FTC nonetheless came back and said, well, look, what you've really described here is separate, parallel organizations, all of whom are separately doing the same thing. They're all doing diabetes care the same way, but there's no integration of these programs across the PHOs. There's no common administration. There's no common medical director. There's no common infrastructure other than this information technology by which you're assessing whether people are complying with the protocols, to really say that this is a singular approach, a singular process that is integrated across the PHOs. And that's the challenge when it comes to clinical integration. It's one thing to do it on a separate but equal basis in parallel within these organizations. It's another thing to create the integration from an administration and operational point of view so so that you can truly have clinical integration to support joint pricing. So I don't think you generally in these organizations, at least quickly, get to joint pricing on the back of clinical integration. You may get there on the back of a combination of clinical integration and financial integration, to the extent that there is true shared financial risk being taken across the organizations, across the hospitals, across the PHOs, through the VCA platform. And in order to get there to be substantial financial risk, generally 10 to 20% of the revenues under the contract or across all contracts would need to be on some shared risk basis. And by shared risk, I mean that each organization is at risk for the cost, utilization, and quality decisions that are made by the others. So for instance, if you were to set up separate risk pools for each hospital and its PHO, so that each other component of the system is firewalled from the deficits and decisions that are made by other PHOs and hospitals. That is not shared risk. If you have a single risk pool in which all revenues and all deficits are combined and all organizations are at risk for the quality, cost, and utilization decisions that are made by other components of the system, then there is shared risk. And with that type of shared risk, to some extent, coupled with clinical integration, you may well, within some reasonable period of time, get to the point that you can do single signature joint contracting, collective bargaining for rates consistent with the antitrust laws. When you get there, there's no magic bell that sounds that says, you are now sufficiently clinically and financially integrated to do joint contracting. You really should do this carefully and thoughtfully in consultation with healthcare counsel. And if there's any serious question about whether you've gotten there, I would suggest an FTC or DOJ business review letter or advisory opinion to validate it. We're getting toward the end of the hour. There's much more we could talk about, but let me stop here. We've got a number of questions that have been teed up, and perhaps we can take at least one before we have to sign off. So let me see if I can get all questions here and take the first one that came in. Although some may have already, I saw more questions earlier. So the first question I have here is, what is a standstill agreement? I guess I can start with that and anyone else can weigh in. But a standstill agreement basically is that there will be exclusive negotiations for a period of time. So in the standstill agreement for the VCA network, what each of the hospitals that signed that were effectively saying is that they're not going to enter into discussions with a competing health system or with other hospitals to form an alliance or network of a nature similar to VCA's with anyone else. So they will stand still in relation to those kind of discussions and only engage in those kind of discussions with the VCA. Next question is there a right of first refusal on changes in ownership? That's a great question. The answer is no, but one of the business principles that the VCA hospital CEOs asked for as we went into discussions about structuring this particular organization, they did want an opportunity to be able to join or have a change of ownership while they were a VCA member and not have any disincentive built in that would create strategic dissonance with that decision. So while they're making fundamental commitments to VCA, there was a recognition that some of the hospitals may, for access to capital or other purposes, nonetheless feel at some point, and their board may come to the conclusion at some point, that they need to explore or pursue another option, another major strategic option that may involve a change of ownership with a healthcare system, and that there shouldn't be any restriction or constraint that would prevent that from happening or disincentive it from happening if it really had to happen. And we balance that out in the buy-sell provisions of VCA. Under most scenarios, you cannot get out whole. You can only get out half of the fair market value of your your interest or liquidation value of your interest if you were to withdraw or leave VCA. The one exception, really, the one principal exception, is a change of ownership. If there is a change of ownership, you can get out for full fair market value of your then interest. But that was a special feature that was desired from a business perspective from the VCA CEOs. Pat, you may want to comment on that.
No, I think you covered it. There was a question earlier, Michael, that sort of jumped off the screen that I think Nellie should sort of tackle, I think, and maybe the person could retype it in, but it was if you were the low-cost provider in your marketplace, one, do you join Alliance, and two, if you do, how do you decide on who else to bring in when you've already positioned yourself strategically for sort of the value environment that's coming? What's the advantage of being in an alliance if you're already there as an individual? Nellie, maybe you want to sort of try and handle that one.
Yeah, I think it goes back, Patrick, to what you're trying to achieve as a single independent entity versus what you can achieve as a collective. And being a low-cost provider in an environment where others are gaining ground on payer contracting or physician integration or acquiring the tools and resources for population health management, it's not all about just how you're doing as an individual on your cost. I think that the network presents a critical mass opportunity for payers who want to quickly change their trajectory in a marketplace. I think probably another important aspect of that question is how do you determine who else you want to buddy up with?
Exactly.
And that's where the whole question of what is the commitment to performance targets among a group of organizations going to be. We did a lot of data analysis in the marketplace. We requested potential members fill out a capabilities assessment. We dug into cost report information. The state of Connecticut happens to have a treasure trove of information that we could take a look at, but in other states, many other services are available. So determining who you want to have in it, yes, you have to look at cost and quality, but you also have to look at some of the other factors that you laid out, Pat: essentiality in a marketplace, level of physician integration, willingness to commit to performance targets, all those kinds of things.
Great.
I hope that enlightens a little bit.
That's excellent. So I want to thank the faculty for today's program. Before we sign off, I promised people I would give you the second CLE code so that those of you who want to apply for CLE credit can do so. So the second CLE code is STFR. That's S as in Sam, T as in Tom, F as in Frank, R as in Rachel, STFR. So thank you very much for joining us this afternoon for this provocative, hopefully, and informative webinar. I know that I learned a lot and really very much appreciate our co-presenters joining us today, participating, and providing excellent presentations. Thank you, and we'll hopefully hear from you on future webinars. Take care.
And this concludes